Assalamu alaikum dear doctors. In this video I am discussing how can we take gross motor development. So first history. When there is they tell me the gross motor assessment, what history we can ask. First the head for cause identification head, any bugs in the brain, size of the head, any trauma and ask in detail if imaging done, what was the finding. Fears, if maintained on medications. So any seizure and the child is taking any medication we will ask. Any abnormal movement. Sentiles is very important. Perinatal, natal and postnatal history, that is prematurity, fast cry after birth, admission to NICU, in details we ask. Neurocutaneous lesions, for any rash in the body we ask, because neurofibromatosis and tuberous sclerosis 2 disease. Family history of the same condition, congenital myopathy and DDH we ask. And nutritional history, one exam case was rickets. So rickets also come. We know that rickets figure is bowing of the leg, there is swelling of the wrist and macrocephaly, that is the increase, frontal bossing. And home modifications, easy access to hospital allowance, transportations and living, open access card and emergency care plan. Is he or she wearing bracelet? For feeds, that is history ask. School, type and attendance, performance and anyone talk to you about EHCP. I am again repeating in gross motor what history we ask. First head, the bugs, size, trauma and ask in details if imaging done, what was the finding. Feeds if maintains on medications. Abnormal any movements. Sentiles is very important. Perinatal, natal and postnatal history, that is prematurity, fast cry, admission to NICU in details. Neurocutaneous lesions. Family history of the same conditions, congenital myopathies and DDH. Nutritional history we ask because one exam case was rickets. Rickets come. And home modifications, easy access to hospital, allowance, transportation and living, open access card and emergency card plan, emergency care plan. Is he or she wearing bracelet for feeds, school, type and attendance, performance and anyone talk to you about EHCP. When we assessment of gross motor, we remember to ask about the gait. Either the gait is hemiplegia, diplegia, lots of things. Upper limb position and abnormal movements of the upper limb. Any apparent facial deviations. Age of the both right and left side if suspecting hemiplegia from the history. Age of the upper limb and lower limb if suspecting diplegia. Again repeating, what we ask in assessment in gross motor, especially the gait. How is the gait? Upper limbs position and abnormal movements. We know that hand movement present on Rett syndrome. Any apparent facial deviations. Age of both right and left side if suspecting hemiplegia from the history. Age of upper limb and lower limb if suspecting diplegia. Some important exam cases, gross motor development, full development, that is Down syndrome, rickets, Sturge-Weber with hemiplegia, CPU with diplegia, CPU with global developmental delay, DDH, congenital myopathy, tuberous sclerosis, sickle cell anemia with stroke, shaken baby syndrome, operated brain tumor. So Down syndrome, we know that the universal features and also hypotonia, mother tell you. Also Down syndrome, we ask about any cardiac lesions, any team he is following, and thyroid status we ask. Rickets, we know the rickets feature, that is frontal bossing, chest findings, there is bowing of the leg, and nutritional history is very important here, and wrist joint swelling, these are. Sturge-Weber with hemiplegia. So in Sturge-Weber what we find, first that is Portman stain, that is some reddish spot, and Sturge-Weber syndrome, that is the child can be wear any eyeglasses, and there is a history of any surgery for glaucoma, and seizure history can be present with hemiplegia. CPU with diplegia, so diplegia, the walking, and the CPU, perinatal asphyxia, that is delay crying after birth, any NICU admissions, ventilations. CPU is global developmental delay, DDH family history, birth history is very important, walking pattern, the gait, that we ask. Congenital myopathy, that is hypotonic, we ask. Tuberous sclerosis, we know that tuberous sclerosis, that is autistic behavior. Number one, that is some chagrin patches, some capsular spot, these are the features present. Seizure present, infantile spasm, so tuberous sclerosis that. Sickle cell anemia and stroke. So sickle cell anemia, we know that the child will be anemic and it present with stroke, sudden pain, dactylitis, these are. Shaken baby syndrome, there is a history can be present like some any trauma, someone shake him or something happened. So past we ask. Operated brain tumor, that is any tumor operation done, we ask about the surgery. any surgery done or not, then we exclude that. Now the DD, what come at the end after history, it can be prematurity. For premature, there is any gross motor delay, then genetic Down syndrome and spina bifida. Down syndrome, Williams syndrome, these are the syndromes come. Neuromuscular disease like myopathy, Duchenne muscular dystrophy, CP, spinal muscular atrophy. These are hypothyroidism. Hypothyroidism features, we know that is he has recently developed obesity, lethargic, the child is gaining weight and achievement is decreasing. Mechanical and or anatomical DDH trauma. So any trauma we ask DDH, development dysplasia of hip, his gait, family history, birth positions, everything. Sickle cell anemia and other bleeding disorder with hemiplegia. So these are the DD normally common gross motor history. Please do subscribe and share. MRCPCH with Dr. Imma. Thank you.